what we do is to look at the, what they do is just go into the chest compressions. We already know, since we've been taught this before, that when the blood flow stops, we've got to do the chest compression. It essentially, you place your hand in the center of the chest. There used to be where you go 2 fingers above the xiphoid process, but that was too confusing for most. So you take your hand, the heel of your hand, and you put it in the center of the chest, center of the sternum. On an adult, you would push down 1.5 to 2 inches, okay, and at a rate of at least 100. So just like you see here in the pictures that are coming up, what you want to do, you need to lock out your elbows. There's different type of grips that you're able to do, but essentially you have to get your hand in the center of the sternum. If you're the first one, if you're the first person that does the compression, it is very important, because when you push down a few compressions, if you do decent compressions, you're going to leave a little divot in their chest. So the person that comes up behind you, if they can't find that, then, I mean, if you go down too low, then they'll be too low. So they'll have to come up here and create a bigger hole in their chest, divot in their chest. If you go too low, you risk getting on top of the xiphoid process that could lacerate the liver. So just like you see this guy up here, his arms are locked, he's straight over, he pushes down and allows the recoil to come fully up. 1 per minute, or 100, is greater than 1 per minute, right? 60 would be 1 per second. So you have to do, a second and a half, compression, every probably half second, 3/4 of a second, you need to do a compression. It's important to push in and allow the heart to recoil. If you don't allow the heart to recoil, it's not going to expel the blood in the way that it should. So fast and deep, 100 times per minute. And you can see this line here. This is what we're doing. This is a very good picture of the coronary perfusion pressure. You're building up pressure, it flatlines here, and now it's pushing blood out to the coronary artery. Here is where you stop. See how drastically it stops when you stop compressions? Then you have to build it back up again. That's why it's very important to continue compressions. When you're in the hospital, you guys that did CPR in the hospital, they didn't want you to wait very long. When you switched out, they're like, switch, and you jumped up in there, you're down, you're up, and you're doing compressions. So it's very fast, very good switch. They don't want that coronary perfusion pressure to drop. You need to continue chest compressions. You guys get tired, right? It's very tiring to do chest compressions. So even if you're in shape, it's tiring to do chest compressions. So you're going to have to switch out. There's going to be a number of you where you don't have to switch out to do good, adequate chest compressions. One thing that we'll look at, let's look at this for a second. When you look at the monitor, when you look at a cardiac monitor and you're doing good chest compressions, the rhythm on the monitor will look like these little humps here. They'll be doing that. If you're not doing good chest compressions, one thing that you'll get is you won't get a mechanical pulse. Your chest compressions should produce a pulse. If it's not producing a pulse that you can feel, then you're not doing adequate chest compressions. But if you look on the monitor and you're seeing that, see the amplitude of that, the difference, you're not pushing deep enough in the chest. So they're going to see, if they see that on the monitor, they're going to say, push harder, push harder. You got to push harder, so you get that amplitude like that on the cardiac monitor. Minimize the interruptions so you don't drop that cerebral perfusion pressure. Very, very important. And we know that in the hospital, when we do that, most of the time they're going to be intubated, so you don't have to worry about pausing to breathe. What happens there when someone's intubated and you're doing chest compressions, the person bagging or doing the bag valve mask looks for you to come up, and when you come up, they squeeze the bag. 10 times a minute or so. There's different ways, like he's shown here. He's grabbing his wrist and doing it. It just depends. You can interlace your fingers. You can grab your wrist. It just depends on really you and the technique that you like to use. It is important, though, to stand up over, lock your heels. If you're on the floor, you need to get sort of closer to the patient. If they're on the bed, then like the stool, right? For us short people, you got to get on that stool, get over the top of them. Some of them have a CPR bed that drops the bed lower, but it's important to get in this position, sort of upright over the patient, so you can stand up there, lock, push down. It says at least 2 inches. Let it fully rebound 100 times per minute. Very important to keep that rate up. If you're going too slow, they're going to be ineffective. They're not going to help out the patient very much. The child is the same way, except in the child you just use the one hand. Can you imagine, on the child you use both hands and you get over the top and you're just pushing too hard and you start to feel a little spine? You got to be very careful. That's a joke. You got to be very careful with one hand. The same placement, the same deal, the same rate, at least 100. I recommend 120. So if you can get 2 compressions per second, all that just saying do the compressions as fast as you can, as long as you're doing a good compression. Children the same way. There's no really difference in the thing except the one hand. The depth is not as much as you see. 1/3 of the chest of the body, 2 inches. Let it fully rebound. You notice his head's all kinked in. You want to have someone sort of, if you're breathing for this guy, you want to have someone keep his head in a neutral position. So the only difference between the adult and the child on the compression is essentially the one-handed method. Now, some of you guys, not mentioning any names, but you might be smaller than the average bear. So even on a child, to get a good compression, you may have to use 2 hands. Okay, there's nothing wrong with that. That's just good judgment skill. You're just too small to use one hand.
What about the overweight kids that are usually bigger?
Like a man-child?
Yeah.
Then you may have to use 2 hands. If this is Bubba, you got Bubba laying down there and you're going, wow, that's a big kid. Yeah, he's 5.
So generally just go by their size.
Their size, yeah. You have to make the judgment call. Your size. Like with you, if I had to do chest compressions, I would probably only use one hand. I mean, I'm not bagging on you, but you're not much bigger than a child. But if you use both hands, you're going to create some damage. So even though she's a young adult, I would still use, wow, just use one hand. Because you're going to cause too much damage using both hands. And the baby, just the 2 fingers straight over the nipple line, you push down. You'll see it on the next slide, they use the thumbs. My hands are not big enough. I have to use the two finger. I tried the thumb thing last time I had a baby, just to see if I could. Last time I had a baby, infant CPR, just see if I could do that. My hands are too small, so I had to use the 2 finger method. 1/3 the depth, 1.5 inches. It says at least 100 times. They're just trying to standardize things. But for this infant, you need to do compression. Once, probably about 120 beats per minute. Okay, 100 beats on an infant is too slow. But just push the finger down, and they're very pliable. They're made of cartilage, so you won't have a huge thing. It's not like on an adult where they're more bone. The infant's chest is very pliable. And then there's the 2 thumb method as well. Just depends on the size of your hands. So you're going to separate, when you do the compressions, you're going to separate the sternum, the cartilage from the sternum, and then have that free-floating sternum in there. And then the sternum and the heart, the spines don't compress together in order to hopefully pump the blood out of the heart. The other thing are the rescue breaths. Like this guy's breathing off of a face mask. So we know, right, that room air is 21%, correct? We exhale 16, 17%, 16 is what's on your test, so 16%. So we use 5%. So when you're doing mouth to mask, you're breathing in 16% air, right? 16% oxygen. So that's something that you wouldn't, you do the compression ratio of 30 to 2, correct? So you do 30 compressions and then 2 breaths, slow breaths with the ventilation. The problem with the mask and the bag valve mask is overventilating and forcing that air into the stomach. Once the air gets into the stomach starts to distend. Once you get too much air into the stomach, the patient's going to vomit, whatever they got. It's just a matter of pressure. If you're building up too much pressure in their stomach, what's in this don't come out. So in an atraumatic patient, opening the airway is to the head tilt chin lift, right? So we don't do the head tilt chin lift. Open the air. What about a trauma patient?
The jaw thrust.
Right, the jaw thrust. We're going to use the jaw thrust in a trauma patient. What happens here, unresponsive patient, the tongue becomes flaccid. You can't swallow your tongue. It's attached. The tongue's going to become flaccid and it's just going to fall back over the epiglottis. By doing that head tilt chin lift, we mechanically pull the tongue off of the epiglottis. Now, when we talk about airway management in a few weeks, we don't put an airway in there. We don't put something in there where you don't necessarily have to do the head tilt chin lift. Just don't pull the tongue back off of the epiglottis. The tongue in an unconscious person is the number one airway obstruction. Head tilt chin lift in order to pull the tongue back off there. So we open the airway to make sure that there's a passage. An open airway means that there's a passage from the atmosphere, okay, down to the trachea. That's what an open airway is, that you're making sure that there's not an obstruction there, that there's a passage from out here to the lungs. You don't know if the patient's breathing yet, you just know that they have an open airway. How do you check? How do you know in a non-breathing patient if they have an open airway?
Their chest is moving up and down. If their chest is moving up and down.
In a non-breathing patient.
Oh.
Say we think this patient is in cardiac arrest. How do you know that if they have an open airway?
Whenever you blow their chest.
Right, whenever you give them a breath, they'll get rise and fall of the chest. Okay? So you have to head tilt chin lift, look and see if there's any rise and fall of the chest. If there's not any rise and fall of the chest, then you have to give them a breath, and we'll give them a breath with the bag valve mask. If that breath goes in, you'll get rise and fall of the chest. Then you have an open airway. Then you check to see if they're breathing. The B, this is A. Then for B, you check to see if they're breathing. And then you look for rise and fall of the chest. You can put your hand on their chest to see. Or you can do something really medical and get a stethoscope and listen, okay, to see if they're breathing. See if you can hear lung sounds. And if they're not breathing, what does that tell you? I mean, just at that moment, they're not breathing. They have an open airway, but they're not breathing. What does that tell you? So you're at that point. You have an open airway. You look, you listen. No lung sounds. They're not breathing. So what at that point do you know? Huh?
They have cardiac arrest.
Cardiac arrest means what?
Other pulmonary arrest.
Pulmonary or respiratory arrest, right? So then, at that point, we open their airway, we look, breathe in, rise and fall of the chest. You got rise and fall of the chest. They have an open airway. We look to see if they're breathing. They're not breathing. They have no lung sounds. Then we know at that point they're in respiratory arrest, at least. Then what do? Right, we check a pulse. Where do we check the pulse at? Carotid pulse. For how long? 10 seconds, right. So you check that pulse for 10 seconds. If there's no pulse, then what are they in? Cardiac arrest, cardiopulmonary arrest. Then you would do CPR, correct? At that point. You have to make sure that you understand the difference between those two. This just displacement of the tongue just tells you that the tongue gets in the way. It's a huge barrier, especially in children. This gives you just a picture of the head tilt chin lift method that we'll practice here in just a couple minutes. Put your hand on their forehead and just push up in a non-traumatic patient. And just lift up. It's quite easy to do. Most of the time people will not lift up the head enough. It's a drastic thing. It's like this. So most people just lift up just a little bit. It's like this. You're really stretching the neck out when you do that. Always, and we know this already, airway's priority. Make sure if you don't have an open airway, then it doesn't really matter if you're not breathing, right? There's no air going in. You have to make sure that you have an open airway, a patent or open airway, or nothing else matters. In trauma, we talk about CABCs. You want to hold the cervical spine. You don't want to create a paraplegic by doing a head tilt chin lift. So you hold the spine, all right. And then, like we're saying, always use a barrier device. That's a no-brainer. The face mask fits over the patient just like the bag valve mask does. So there's really no difference in between this face mask. Use that EC method that we learned, and then you just blow a constant breath, not a big breath, but just a constant breath over a period of about a second or 2 seconds, so it doesn't go into the stomach. If you just do a big push with your breath, most of it don't go into the stomach. Opening the airways the same way. You give the breath there, and then just like we were saying, don't go too forceful or too long because you blow air into the stomach. You notice that all the barrier devices are clear. Even the bag valve mask is clear. Why is it clear? All right, so you can see when they throw up. Exactly. Infants are the same way, except the masks are a little bit smaller. And I'll break those masks out, and I'll break those bag valve masks out in just a second, and we'll look at that. You just want to make sure that you have the appropriate size bag valve mask, BVM, because if you get too large of a BVM, you're going to hyperinflate the child and the infant's chest wall. Remember, what's the normal tidal volume for an adult? What's the normal tidal volume for an adult? 500 milliliters is the normal tidal volume for an adult. All right. This bag, every time I squeeze this bag, how much air do you think comes in there on the average?
When it's not connected?
No, how much air am I displacing here? How much air is coming out of here right now?
90 back
Not percentage of oxygen. How much air is coming out of here? 500 milliliters. That's normal tidal volume. The bag, this bag is a 500 milliliter bag. Okay. For an adult, this is an adult BVM. So every time I do this, I'm squeezing out an average of 500 milliliters. All right. And it's a slow, steady squeeze. It's like this. You squeeze and release, squeeze and release. It's not like this. You want to squeeze it and release. The mask and everything fits on just that face mask fits on just like the bag valve mask does. Jaw thrust. I've never really used a jaw thrust because I'm an EMS. We got things to stick in there in their mouth or their nose if we need an airway in a traumatic patient. So we'll show you that. We'll show you the jaw thrust on the mannequin just in case, like you're out at Walmart and someone falls off the building and you want to try to open their airway. But in 20 years, I've never used the jaw thrust. Never had the need to. All right, so we look at the bag valve mask. This part here, it's pretty simple. Bag, right? Well, I'm sorry, bag. The valves up here, and then the mask. This sound that you hear, this clicking sound, you may not be able to hear it, but it's a little clicking sound. That's the valve in there. So you have bag, the valve, and the mask, or BVM. Common bagging. So when I say bag the patient, this is what I'm talking about. That's just sort of the slang term for using the BVMs when you bag the patient. You connect the other end of the bag valve mask to oxygen. When this is connected to oxygen, now tell me the percentage of oxygen that I'm giving. 95 to 100%. Okay, when this is connected to a high flow oxygen, you guys learn about that later, or did you already know? Okay, we'll pick that up later. No problem. So you connect this to oxygen, 95 to 100%. Because what are we breathing now in room air? 21%. So this is going to up the percentage of oxygen quite a bit for us. This is the preferred method. This is really the method that, like EMT-wise, that you would use. You don't carry, on the ambulance, you don't have pocket masks. Why do you have a pocket mask when you have a bag valve mask, right? Not to mention, it keeps you much further away from any vomit or anything. So when you're bagging the patient, you can get at arm's length. When you're doing that whole mouth to mask thing, you're really close to the patient. I don't like that at all. You can see here, the bag valve mask can be used with one person, but primarily it's best used with at least two, sometimes three. So at least two. One holding the seal, you have to have a good seal, and then the other one squeezing the bag. That's the best way to use the bag valve mask.
How would it work with breathe?
When you're using it, make sure that you see good rise and fall of the chest. You want to observe rise and fall of the chest. If this is, it sounds like a lot like someone passing gas. If it has a bad seal, or because the patient's face is probably wet anyway. If you don't get a good seal, it sort of goes like that, and it doesn't. You just don't have a good seal on it. Once we start practicing bagging here in just a few minutes, you'll see the difference on the good seal. You guys practice this, right? Y'all use this? Did y'all ever use one in the hospital? So unfortunate.
Did they do it like on actual people?
So make sure you got a good seal. Use that EC method there. Deliver the breaths. Remember, squeeze and release the bag. Squeeze each breath. Very important. Squeeze the bag about 1 second length and let it go. I got this really cool device that will help you get into the sequence on how to bag. It's sort of gives you a number in a line that's sort of on a rate and depth of bagging. The same thing with infants and children. The mask fits on the same way. There's really no difference on how the mask fits. The thing that you have to remember about infants and children is not to overinflate the lungs. Don't get too excited and overinflate the lungs. All right, the OPA and NPA, this is all stuff that we'll learn in a couple weeks when we start doing airway management. So I'm not going to go into that right now. Advanced airways, most of the time, when you guys are going to be doing CPR, they're going to have an endotracheal tube. Remember last year we practiced in the bag a little bit, and then we intubated the patient. You primarily breathe off the endotracheal tube. That is primarily what you're going to do. Because here's the thing with, like when you get out on your ambulance ride-outs, you got to tell them, you got to remind them that, hey, I'm an EMT student, and I need to do this skill, like this OPA skill. You have to tell them, hey, can I stick this OPA in? And they're like, okay, go ahead. You know, so that's something that you have to jump in there and do. All right, last thing, trauma. When you suspect trauma in a patient, make sure that you hold the C-spine. Do you all know what holding C-spine means? Here, let me teach you in like 2 seconds. Come here for a second. We're going to hold C-spine. That is a major thing. Hey, don't mess this up. You paralyze you. You should never dance on a pole again. Okay? In a car wreck patient, holding C-spine is very important. You've got to have the right technique. You ready?
Okay.
All right. Hold her head. Face this. You're the patient.
Okay.
You don't have to do that. Sit down. Go over there. Behind her.
I didn't wash my hands, I'm sorry.
That's all right. So you can wash your hands. Hold her head. Hold her head. A little bit quiet, a little bit firmer, so she doesn't move. There you go. That's it. Yeah, you want to hold C-spine. You don't want them moving their head. Most people talk with their head. So you ask them a question. Are you hurt? Yeah. You want to go to the hospital? No. So they move their head. So you hold their head in case they have a spinal cord, a high spinal cord injury, a cervical spine injury, that you protect their spine. Neck and spine. That's why we would put them on a backboard. And then the jaw thrust method is used for all trauma patients. CPR shield we'll talk about in a minute. It's sort of the same thing. The opening the airway is the same. Breathing. No barrier devices. You're out of your mind. Okay? When you do that.